go.
I love it. I'm excited to be back. Tyler, welcome back to our next episode of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis, physician assistant. I've got Tyler Murray with me, as always, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. The reason we're doing this, the purpose of the podcast, is to get to know everybody. We want to explore all the different spaces where advanced practitioners work. What's your life like? What are the struggles you face? What makes your specialty special? And ultimately, how can we help each other to provide better patient care?
And where would we be without a general disclaimer? This podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to act as a substitute for medical professional advice, diagnosis, or treatment. We're just here to chat, get to know each other, and have a good time. With that, this week's podcast is on oncology. So a space that you had just alluded to, hey, you know a little bit about, and Alex and I looked at each other and said, do we though? Yeah. So we're super excited to jump into this space. And we have with us Jake, who's been a nurse practitioner for quite a few years, been in the oncology space for that entire time. Is that safe to say?
4 years.
4 years. So with that, I'm going to turn the mic over to you and let you kind of just introduce yourself and kind of how you got to oncology.
Yeah, I kind of fell into oncology, but we'll get to that. So I grew up here locally. I went to UVU after Alex probably knows my brother, actually, or knew my brother that passed away. He's a couple of years older than us.
Yes.
He passed away in 2007, and I was really impressed with the nursing care that he received. Even though he passed away, I was impressed with the nurses that took care of him. So that kind of what spurred me to get into nursing originally. I always knew that I wanted to do something in the medical field, but that really was like nursing is where I'm supposed to be. So I applied for nursing school at UVU, got in, graduated from there with my associates, started working at the University of Utah in their inpatient medical rehab unit, nights and weekends for the first year of my nursing career while I was going to school to finish up my bachelor's. Got my bachelor's and decided University of Utah was too far of a drive for me living in Utah County, so applied for places down here. Got a job at American Fork Hospital on their medical surgical floor, and I've loved it there. That's home for me.
Mm-hmm. And it's a little bit smaller facility too.
Yeah,
a little bit smaller community hospital.
Yeah, and I really like that feel.
Yeah.
So it's a good place to be. I worked there as a nurse for 4 or 5 years, and decided to apply for NP school. When I first got into nursing, I thought I'd be a CRNA, but decided I liked my patients awake.
Yeah.
I went the NP route and got into BYU. Was working full time on AF Med-Surg. So every Friday, Saturday, Sunday for 2.5 years, I was at the hospital and doing school the rest of the time.
Man, that's a tough balance.
Some people will ask, like, would you do NP school again? And I don't know that I would do it again, but I'm glad that I did it the first time.
Right, yeah.
So
that's funny. We have Mount Timpanogos right behind us, and it's a popular thing. A lot of people do it. We'll hike to the top of Timpanogos. And I have the exact same expression. I tell people the same thing. People ask, hey, should we go hike Timp this summer? And I will say, I've done it once, and I'm good.
Right?
I'm glad I did it once. Probably not going to do that again.
Yep. So I finished up at BYU with my master's degree and then started applying for jobs. It was kind of the middle of the pandemic, right? I graduated in December of 2019, started applying for jobs. It takes a while for certification, that sort of stuff to go through. So I got a job with Revere Health in oncology, hematology in the middle of 2020. So kind of a steep learning curve there.
Yeah, I can imagine.
Getting thrown into oncology and hematology and having to know everything.
Yeah, because coming from Med-Surg at a smaller hospital, I mean, you just don't get the exposure to that, in my opinion. Maybe you could say otherwise, but
yeah, I think you do kind of, because it is a smaller hospital, so it's not the floors aren't like subspecialties, right? So you get everything. You get pediatrics, you get pediatric appy, you get a 101-year-old urosepsis, right?
That's true. I retract my statement.
So you get a good variety there. Oncology, though, not so much. The exposure I got there was with Dr. Tintzer, is the kind of the breast surgeon of Utah County, right?
Yep.
So taking care of her patients, and I 100% believe that she helped me get a job in oncology, because the oncologist at Revere reached out to her because I mentioned I worked with her in an oncology setting.
Of course.
That's awesome.
And I'm 100% confident that she got me a job there.
Awesome.
That's probably always going to be the case.
Yeah. So I worked there for a couple of years, and then I kind of kept my foot in the door with Intermountain as an RN, picking up PRN shifts here and there. They would pay me well. They'd usually pay me time and a half, which is about the same as NP wages. So it made it worth it. So
wow.
So when Intermountain had an oncology job, I applied for it, and that was kind of one of the hardest decisions of my life, actually, leaving Revere, because I really like the people over there.
Yeah.
So, but I've been working with great people at Intermountain as well, and I've been doing that for two years now and loving it. And
for our listeners, maybe just to distinguish there, so Revere's kind of it's not a hospital organization, it's a big system that's been created, multi-specialty clinic, whereas Intermountain Healthcare is a hospital organization. So yeah, I do think there's differences within that, but also similarities, because in my opinion, they're both big machines, right? And so but there is some security behind that as well. I want to go back to when you became an advanced practitioner and got into oncology. What was the learning environment like for that setting? What were you involved with in that capacity and learning?
What would someone expect trying to jump into that specialty?
Yeah, there's a lot of shadowing first off, and shadowing different providers there, whether it be the physicians or other nurse practitioners. They did not employ any PAs there, actually. I think there was a rationale for it, but I don't exactly know what it was.
Yeah.
Just a lot of shadowing, and then a lot of reading up to date.
Up to date. We love that.
And then another resource for people in oncology is NCCN guidelines, National Comprehensive Cancer Network guidelines. You guys are looking like you don't know what that is at all.
I'm not familiar with that
one. I'm shaking my head, yes, but I don't know what that is. But I can assume it's out there.
Yeah, it's a free resource, actually. You have to have an account for it. You can log into it. There are paid subscriptions for different resources there too. But the general stuff, you can just log into it and get a free account and have all the, for lack of better term, or lack of better words, it's a cookbook for cancer care.
Okay.
So
just as a database of all the guidelines and
lots
protocols
of algorithms and yep.
Of course, yeah, that makes sense. I'm sure that's going to be a helpful resource to rely on. So what that kind of alludes to what's your day like in the clinic, because I imagine you're in a specialty that's probably less procedure based and more medical management.
A lot of medical management, yeah.
Following that kind of stuff. What kind of conditions, what kind of patient population, or what does your average day look like?
Yeah, a few different questions there, I think.
Yeah.
So
sorry, I gave you a lot.
No worries. So patient population, we treat adults with cancer or hematologic conditions. Really anything that's not an acute leukemia, we see.
Okay.
Acute leukemias go up to bone marrow transplant. Day to day kind of varies quite a bit, actually. I said I'm in hematology and oncology, but I actually work in medical oncology and radiation oncology. So I split time between two different clinics and two different locations with those two different clinics. So I'm in a different place each day.
Okay.
So I do 2 days a week with radiation oncology. Those are seeing survivorship mostly. I will do some consults, prostate cancer consults mostly, but anything else that comes through the door as well.
Okay.
We see. And then again, reading a lot of up-to-date and NCCN guidelines. Procedure-wise, I do a few procedures. bone marrow biopsies. Do quite a few of those.
Oh, yeah.
In clinic. I tell people there's two options. And it's the same procedure. We can either do it in clinic or we can send them to interventional radiology to get that procedure done. I tell them that interventional radiology is nicer because they use sedation.
Yeah.
So, but yeah, so I do a few procedures. I do go to the OR with Dr. Barney he's the radiation oncologist, to do brachytherapies, which is a treatment for prostate cancer and other cancers. But specifically for prostate cancer, it's where they insert multiple needles into the prostate through the perineum, right? When you start seeing these procedures, like, who developed these procedures?
Is there? Can I just get this? Is there sedation for that one?
There is.
Okay.
There's spinal.
Okay.
There's.
Okay.
You're there. You're there.
Yeah, and they're not little needles. They're like 18 gauge needles, and there's like 18 to 20 of them.
18 gauge needles in the perineum. Right. Yeah.
People do great with it though. Like
Prostates love that.
Right? No better way to cook a prostate.
So what is the
That's a t-shirt slogan.
Yeah.
Okay.
So what is the treatment there? What are you actually doing though?
Yeah, so it's delivering radiotherapy to the prostate at a higher dose. It's a more localized treatment, and they can deliver a higher dose to where they want it without damaging
Higher
the surrounding
concentration.
structures.
Yeah. Okay. That's crazy. The more you know.
We gotta move on.
Yeah. I'm starting to hurt. Getting comfortable here.
What are your favorite things to do in the clinic? What kind of conditions do you like to treat?
A little of everything, right? The variety keeps you on your toes, and I have a hard time letting go of things too. I think that's why I kept being a PRN nurse for so long.
Sure, yeah.
So when I learn something, I like to practice it. So I like to see everything.
Yeah.
I do like to perform bone marrow biopsies though, because that changes up using my hands instead of just my brain.
For sure.
Yeah.
For sure.
So what is it that your schedule looks like at present? How many hours are you spending working? How much time do you have off?
Yeah.
What's the work-life balance?
It's pretty good, actually. I only have to, I get paid a salary. So I only really have to be there when the patients are there. I usually try to get there an hour before patients, but if I only have a couple patients, I only see the couple patients and I go home. They can call me and I'm happy to come back to the clinic. I'm not that far away. But a few months ago, I told my boss that I don't think I've worked a 40-hour week in the 2 years that I've been here.
Oh my goodness.
So I think that Intermountain, starting their medical oncology practice in Utah County a couple of years ago, 3 years ago, we're still growing. So they've hired 3 physicians since I've started. So most of the patients are being established with those physicians. Mm-hmm. So it makes it so my practice is a little bit slower to grow.
That makes sense.
But yeah, it's pretty good. Again, 2 days in radiation oncology. Those are kind of, I don't want to say easier days, but they kind of are easier days because it's like we're focused on radiation. We're doing radiation. That's all we're doing.
That's it.
Medical oncology, you have all these different medical issues that pop up, and you have to manage the nausea, the constipation, diarrhea, whatever it may be. So.
Oh, wow. Okay. And then what's your solution to all of that? Because I imagine if somebody's in the office with an oncologist, they have to have some fairly significant comorbidities as well. Kind of where do you draw the line, and where does your scope of practice kind of end, and then using the other collaborating providers?
I don't think the scope of practice is limited there, other than saying what chemotherapy regimen they should be on or changing therapies. But it's within my scope of practice to say we're not treating today, or we're reducing the dose of this chemotherapy agent. There are lots of different comorbidities in oncology, though, for sure. And I tell people when they're diagnosed with a cancer that it's impossible to have a diagnosis of cancer without some anxiety or depression, or both.
Right. Yeah, and that was kind of where my thought was going to next as well. I imagine your conversations with patients may be quite a bit different than maybe what I'm having with patients in my clinic, because there's there's a lot of anxiety. If somebody is, again, sent to oncologist, the diagnosis of some sort of cancerous lesion or cancerous condition, people are probably a bit high strung coming in to see you for the first time.
They are. Yep.
Tell us how that interaction goes.
So again, I see hematology and oncology patients. So when a hematology patient comes in, if it's like an iron deficiency anemia, I try to lead with saying, you're in a cancer center, but this is likely not cancer.
Right.
Try to ease those nerves initially there. Yeah. So.
Yeah, and then what about the patients that we would send to you in neurosurgery? Probably the most common one I think that we come across is GBM or glioblastoma, which we know a fair amount. Okay, we can check one thing off in your world that I feel like we know something about. But those patients are going to need your services and need your expertise. So how about somebody in that situation where we know that glioblastoma, being called a life-shortening disease, there's some information they're going to want to get pretty directly.
Right, and that's a stage 4 cancer. A glioblastoma is a brain tumor that's a stage 4 tumor, even though it's only in the brain. So different cancers are staged differently. So with glioblastomas, yes, neurosurgery gets involved to have the maximum safe resection, and then get sent to oncology to do radiation and temozolomide, which is the kind of the standard of care. And now there's within the last few years, they've come out with alternating electrical fields, and there's devices that people wear on their scalp for 20 hours a day. So they have to shave their head, and it has shown an overall survival benefit of like 5 months, which is huge because the addition of temozolomide was 2 months.
Oh, wow.
Oh, wow.
So
that's impressive.
Fairly significant benefit.
I think maybe a little bit just the emotional support aspect of it is, do you guys have counselors in the office that work with these patients?
Yeah, we have a whole team. We have the physicians that are oncologist, hematologist. We have one nurse practitioner, that's me. I'm the only APP in our practice. But we have clinic nurses that can help triage things. We have financial navigators that help get things paid for.
Yeah,
Cancer's
that's probably
expensive.
a big part too. I didn't, yeah.
And then there's social workers too.
Wow. So it's a whole team within the specialty.
I'm probably missing people too. There's MAs and other people part of the team, and front desk. Everybody on our team are amazing.
So how often are you seeing a routine patient in your office? That varies, I assume.
It depends on the regimen. It's every 2 weeks to every 3 months if it's an active kind of treatment. I guess with like breast cancer, we can see them every 6 months, even if they're just on a hormone therapy and doing well on it.
And are you the go-to provider in that setting then? Are they always coming to you? When do you distinguish an advanced practitioner versus the oncologist?
We don't really have a set protocol for that yet. I kind of alternate. If the physician is booked that day, I'll see the patients. So I see whoever's on my schedule. I don't ask questions about why is this patient on my schedule.
Sure.
I just see them.
Sure. What do you wish other people knew about your specialty? I guess how can we as a community help in what you're doing and help you guys provide better care?
Catching cancer sooner.
Yeah.
Love that answer.
Sure.
Love that answer.
I shouldn't say hate to see them. I don't like when 20-year-olds have metastatic colon cancer.
Yeah. Yes.
That's a rough situation. When people have a stage 4 cancer, if it's a glioblastoma or if it's a stage 4 colon cancer, we tell them that's not curable.
Yeah.
We can treat and help prolong life and help minimize symptoms, but that disease is going to take their life. So catching cancer earlier, if you have symptoms of cancer, if you have rectal bleeding, go talk to your doctor about it.
Yeah.
Like that can be a sign of colon cancer.
Yeah.
So,
and maybe one thing to add to that, I've tried to implement in my practice. I can't count the number of times that I've read a radiologist impression and there's a finding outside of my scope where there's a lesion or something like that found. I think it's so important for providers to remember that patient coming in may not have anyone else review that image with them. And so if you see a finding that's outside of your scope, the patient should be made aware so that appropriate follow-up can take place. I found that a patient has come in, I've seen them, and then they leave, and then I go back and I'm revising the note and I realize, there was a radiologist impression and they want follow-up. I call the patient on the phone and ensure that, and I'm sure I've missed some too. So I think it's just raising awareness, right? It's trying to catch things as early as possible. So
yeah, and that attention to detail too, right? Actually reading the report, not just saying this is my finding that I'm concerned about, right?
Yeah.
Mm-hmm.
So yeah,
absolutely.
Yeah, in the spine, we'll commonly see comments about a thyroid nodule or a mass on the kidney or something like that.
Absolutely.
So yeah, that definitely supports that as well. And we had a common friend that we grew up with. I'm sure you heard the story, and I won't say names, but somebody our age that recently, just in the last year or two, passed away from colon cancer, which he would have been in his 30s, would have been early 30s as a first diagnosis, which is even before the recommended screening tests. So,
and other people we've gone to high school with have died from melanoma.
Yes, yeah.
That was 10 plus years ago, probably.
Yeah.
So yeah, it happens to us.
Yeah.
Right? Even our young adults.
Yeah.
Yeah, that's the reality of it.
Yeah.
For sure.
Yeah, definitely a key takeaway to be vigilant and know that, things outside of the textbook standard patient population can still exist, and do your appropriate diagnostic workup.
And I think that information applies to us as providers, because I know we oftentimes neglect ourselves. Self-care, I think it's important to get the screenings as we should,
100%.
as we're recommending. Are we buying what we're selling is what I like to say. So definitely a shout out to get your annual screenings and make sure you're staying up to date on the things you need to be doing to take care of yourself.
Mammograms starting at age 40 for women, and then colonoscopies at 45 for everybody.
Love that.
Sooner if you have a strong family history.
45 is the new 50. That's
Exactly.
what I hear.
Yeah, I love that.
Exciting. How about maybe some success stories? I know there's probably enough that you guys, enough of the heavy material that you get to deal with. How about some of the success stories?
Yeah, I love to treat non-Hodgkin's lymphomas. They melt away. We cure people. They're on death's door when they come to us, and you just see them improve drastically over even a couple weeks. That first chemotherapy treatment, you can see that they're feeling better.
That's awesome.
It's weird that they feel better when we're poisoning them.
Right.
Yeah,
Yeah, that seems counterintuitive.
that's true. I had a patient come in. This was several months ago, and she came in with chief complaint of neck pain and sudden onset unilateral swelling of her neck. And she had described the symptoms as a fairly sudden onset. She had been driving for several hours and thought it maybe was the result of turning her neck repeatedly. And, she just had this large swollen mass on the side of her neck. And I was so zoned into spine, and I'm like, okay, how did you injure yourself? What injury did you have? And lo and behold, she had lymphoma. And so, it just goes to show you can't get tunnel vision. You always got to be looking for the outliers. And, she was young, otherwise healthy, and I assume that's maybe, unfortunately, the population that it can sometimes hit. So
It is. And then we've got to look for secondary cancers in those situations too, because when you're diagnosed with a cancer so young and treated for cancer so young, sometimes the treatment of that cancer can cause a secondary cancer decades later.
So all the more reason to early intervention, information, education, screening.
And then survivorship too. Make sure that you're seeing your oncologist or at least primary care doctor to follow up on those NCCN guidelines for survivorship.
Sure.
I love that.
How available are you guys in your office? I mean, if somebody needed to get somebody over, is there?
Let me jump in. So with that patient,
Yeah.
I reached out to the radiation oncology team, just cold call. Just called them and said, hey, I'm Tyler with Summit Brain and Spine. I've got a patient that, I got a CT neck and there's concerns for possible lymphoma. Can you see him? And literally, I think it was like 2 days later, I had gotten a message back. The patient had been seen and screened, and a plan in place was already in motion. So pretty
Yes.
impressive.
Yes, we're available.
Sorry, I didn't mean to steal your thunder.
No, that's perfect. That's better than I could say it.
Yeah, so fairly available. If there's a need, an urgency, or a concern, it seems like you guys are responsive and kind of understand the need.
Which is reassuring to the community. I mean,
absolutely.
that responsiveness is so imperative because, this young gal had parents that were concerned. There's so many other emotions and circumstances in place that, it really takes a team.
I saw one recently that was had come in, scheduled a regular new outpatient visit in our office, was coming with a brain scan, and just before the patient came back, I took a peek at the radiology report, and it was a small meningioma. It was maybe a centimeter, and not really any mass effect or midline shift, or really symptomatic. We know what meningiomas are. We know the benign nature of those things. But the patient came in and was almost immediately in tears and says, I got this appointment 3 weeks ago, and I didn't know what was going on, and I haven't slept, and I've had all this anxiety and stress, and I just don't know what's going to happen. And she had family members with her in the room, like I was going to just break this awful news to her. And pretty immediately, I got to give her some reassurance, and she was just so thankful just to have some information.
And that patient's going to think you're amazing for that.
It's funny because we know we have the knowledge, but you can imagine from the patient's perception how scary that situation is, because they leave the ER or whatever setting they were, and then you have a mass in your brain. You need to see neurosurgery. That's generally what the patients will tell us.
Information they were left with.
Yeah. So
absolutely, yeah. So being available, I think it can calm a lot of those fears, and even regardless of good or bad news, I think people appreciate information and a plan and what's next. Yep. So that's great.
Let's switch gears. I'm interested in this. So the world of oncology, advanced practitioner, what is the pay look like? I mean, is it comparable to other specialties? You do work for a bigger organization, so I know there's some similarities across the subspecialties, but if you're willing, just kind of let us know kind of where you stand in that bracket.
Yeah, I'm pretty open with financial information, because I think the only people it helps to be hush-hush about it is the big corporations, right?
Right, that's exactly it.
So true. When I started with Revere, I was like, I want an NP job. I don't really care, right? Yeah. I'll take whatever wage they're offering. And I started off at $93,000.
Okay.
Got a 6% raise within a year. And then at 2-year mark, I was planning, or I assumed that I was going to get another 5-6% raise. But at that time I applied to Intermountain and switched over to them, and actually got like a 30% raise switching from Revere to Intermountain actually. Wow. So I make $63 an hour on a what's the word? I'm blanking. Just not an hourly wage, but
a salary.
A salary.
Yeah.
So I make $63 an hour.
Comparative to what a salary would be for a 40-hour work week, which we also learned.
You don't work 40 hours a week, oftentimes.
I still get paid for the 40 hours.
That's amazing. And along with that, there's probably not a lot of on-call evenings, weekends, that kind of responsibility either. Right?
I have zero on-call. I'll go round in the hospital once in a while, but that's not that common. There is an option to be on call. Right now, it's only me as an APP, like I said, in Utah County. So the APPs in Salt Lake County are actually covering our clinic to be on call. So I could join that call rotation. But right now, my life is busy finishing our basement.
Yeah, you're like, I'm not saying a word. Right. They're going to have to tell me I need to do this.
Exactly.
Yeah, that's fair. Totally fair.
Exactly. So that seems reasonable then. You're happy with that. It sounds like competitive and pretty equal across what you'd expect across statewide or nationwide and things like that.
I think so. I don't know what other people make really. So
sure. That's fair. And then like inflation and things like that, do they do a cost of living raise each year? How does that look?
Yeah, actually when I started with Intermountain, I said, I'm going to take the job. I actually got a raise before I started because of that.
Nice.
So yes, they do that.
Yeah. I think that's important to advocate for, because sometimes I think companies can, we're paid good money to be providers, but man, cost of living can really catch up to us. So it's always good to advocate for yourself and it's good that people are looking at that. So,
Right. Absolutely. Well, how about we finish up here with a good patient story? We always like to hear some impactful experience, whether that be, something that just left an impact on you, if it was something fun and entertaining or memorable in any way. What do you think? You got a good patient experience to share?
I don't know if it's a patient experience. I mean, the patient was there, but
The patient was there, so we'll count it.
So going back to brachytherapy, we're in the OR, getting ready to do this procedure, putting needles in a perineum.
Yeah.
And
are they? I have to ask. Are they in stirrups?
They are. Yeah.
Knew it.
Yeah.
I knew it. Okay.
So
please continue.
there's another procedure where they place fiducial markers, little metal coils in the prostate to help line the patient up to the linear accelerator that delivers the radiation. Different than brachytherapy, that's external beam. Brachytherapy is coming from the inside out.
Sure.
But there was a pre-med student that was with us.
Oh, boy.
And we're like, this isn't like an operation. Like it's not that big of a deal, right? And asked him if he's been in the OR before. He's like, yeah, as a patient.
Famous last
that doesn't
words.
count.
Yeah, exactly,
Right.
exactly.
So he's scrubbed into, no, he was not scrubbed in. So it's Dr. Barney and myself that were scrubbed in, and Dr. Barney's doing the procedure. I do place some of those needles too, just to get a little hang of it and learn a little bit, right?
Sure.
But I was explaining to the pre-med student, like, you can see the fluoroscopy image up on the screen, I'm like, so you can see that he's placed 2 of the 3 markers. And I turn around to look at Dr. Barney to see what he's doing, and I feel him brush against me, and I hear a thud. So
Got him. Got him.
he woke up ready to fight too. Yeah, so I was right there. So I didn't care about being scrubbed in. Dr. Barney doesn't need me on those cases.
Sure.
So I helped him and
Broke scrub.
Yep. His mouth's all bloody though.
Oh,
man,
shoot.
he
Had
really
to go to
went
the
out.
ER to get some sutures. And so it's kind of a good reminder for us as medical professionals that this is not normal procedures for normal people to be seeing, right?
Yes.
Like, even if it is just a needle, that's not where a needle's supposed to go. Right.
We were getting squirmish over here. You just describing it.
Yes.
Seeing it in person would be different.
Correct.
Yeah.
So
Man, yeah.
Are we going to name names? Can we shout them out? No, don't do that. Don't do that. I'm kidding. Don't do that. Poor kid. I had a physician I worked with, did some of my clinicals with. I knew him for a long time, but he always had the philosophy that you don't get to see naked people till you're actually in school. So he wouldn't let any of his high school shadows or these pre-med students come do any of the real intensive procedures until they were kind of shown that they were actually into the profession. To probably avoid that scenario.
I think so. Yeah. It's a different environment. So
Yep. Anyway, well, this has been fun, Jake. This is awesome. That was interesting. Got to know a little bit more about oncology. What do you think, Tyler? What'd you learn?
I hope I never have risk for prostate cancer or have to be tested
dude, so
or
you do.
treated. And that is the biggest takeaway I've gotten. No, I actually think that all in all, I mean, I've learned a lot. One thing is like the medical side of oncology versus the radiation side of oncology. I think we oftentimes lump oncology into one umbrella, and they are different, and they kind of have a different mindset and workup and treatment algorithm. So I thought that was interesting to hear about. I love your work schedule, the fact that you're not working 40 hours a week, knock on wood.
Right.
I know that might change as you get busier. It
likely will.
Yeah, it will. But enjoy it while it's there.
Exactly.
And I mean, gosh, it sounds like you've got the right work-life balance going right now and good pay, competitive pay. So overall, I think you're in a good spot. And oncology seems like an interesting specialty to get involved with. Sounds like you don't need to have a ton of knowledge going into it. You just got to have someone willing to
Learn.
drag you along and teach you. So, and be willing to learn yourself too. Yeah. Resources out there for all the standard guidelines. I think that's important for us to remember. So, and then I think, again, as we alluded to, us as providers, just continuing to foster this idea of early screening. If we see something that's a red flag, we get the right team involved to work them up. So I appreciate you coming on today. Learned a lot, had a good time,
Yeah.
had some laughs.
Yeah. It's been great. How would somebody connect with you, Jake, if had some follow-up and wanted to get to know a little bit more? How would someone reach you?
Yeah, I'm at American Fork Hospital in the Cancer Center there, or at Utah Valley in the Cancer Center there. So
Gotcha. Any social media platforms, anything
You don't
like
want
that?
anybody sliding your DMs or what?
I don't have any.
Oh.
Like,
I think that's what you're saying nowadays.
Yes.
Yeah. I don't
That's
have
what the
any
kids
either.
say
So, yeah.
10 years ago.
Oh, my kids don't listen to this.
Okay, well, great. You can connect with our group. I don't run it, but we do have it. We have social media accounts. We like to interact with people, and it helps us to get to know the community better and give us some feedback. We're on Instagram, Summit Brain, Spine, and Orthopedics. YouTube is Summit Medical Institute. And then we really like to see people in person. We get together every Tuesday morning, 7 a.m. for our interdisciplinary case discussions. 7 a.m. Tuesdays, Mountain Point Hospital in Lehi, Utah.
And if you like the podcast, like and subscribe. Give us some feedback. We love reviews. It kind of helps us dial in and fine tune what we're doing day to day with the guests on the show. So yeah, definitely would appreciate any feedback in that regard. I've been meaning to say that for some
Well, I
time.
appreciate it. You got it in there. Shout out to our production team. Always taking care of business on the back end. And we got some good shows coming up, so stay tuned. Cue the outro music. We'll finish up another episode of the Many Minds podcast using Many Minds for better outcomes. I'm Alex Davis, physician assistant.
I'm Tyler Murray, nurse practitioner.
We'll see you next time.